Again, my name is TJ Ferrante. I am a healthcare attorney with the law firm Foley Lardner. I actually sit in the Tampa, Florida office, but I travel across the country fairly frequently, speaking at conferences like this or working with our clients. My practice focus is working with maybe sometimes larger, sophisticated hospitals and health systems, but also a number of smaller, innovative, early stage or startup companies as well to build out telehealth or remote patient monitoring arrangements. In my portion of the panel today is going to talk about, and I'm biased here, but what I think is a very interesting and promising area of digital health, namely remote patient monitoring. I know we don't have a lot of time today. I think it's just like 10 minutes, so I will try to talk fast. But anything's fair game during the Q&A portion, so go ahead and throw those at us. And if you don't have a burning question in front of mine today, you can grab me after this discussion, or my contact info is in the materials. Feel free to shoot me a call or email. Happy to talk shop or walk through any legal brain busters you have. But to jump right in, I want to start with kind of framing what is remote patient monitoring, or what is remote monitoring. RPM sometimes is how we refer to it as well. And generally speaking, what I'm talking about when we say RPM, or remote patient monitoring, is we're talking about using technology to measure or capture patient information, typically biometric data, and then transmitting that information electronically to a clinical care team that's located somewhere else, not in the same location as the patient, right? And it's a very powerful tool, if you think about it, because it allows for continuous monitoring. Typically, these services will associate with some sort of software or clinical algorithm where clinical anomalies can then be sort of fettered out and alerted to the provider or the care team, right? The care team can review that and then intervene if necessary. What does that do? It allows the care team to have a much more preventative and holistic approach to healthcare, right? You can get to that patient earlier, call the patient. Hey, you forgot to take your blood pressure medicine. What's going on here? Rather than waiting until the patient's condition, right, rises to the level of severity where they have to go into the ER or into the hospital for a much more complex, a much more costly acute care episode sort of approach. So that's really the power of remote patient monitoring that's being harnessed here. And that's what I think we really want to focus on and talk about today. Now, some of the use cases that are common in the industry that I've seen today at least involve blood pressure monitoring. You have wound care progression. These are the types of services we've seen, and the type of devices that are associated with that. You see like a wireless scale, right? In EKG, we had several, I think, speakers today tout that, the benefits of that. We saw that the shirt, I think it was Hexoskin, was out today. So that would also be a potential remote monitoring device, right? These are the kind of things you'll see out in the marketplace as well. So to kind of give you all the lay of the land. Now, one of the questions, or probably the question I get most of all is, well, this is great, but how do we get paid for it, right? Is anyone paying for this right now? We'd love to use this. And the answer is yes. And then my next question is, well, do we have to be in a rural area? What about all these other rules that we hear about in telehealth? And I want to kind of talk a little bit about a distinction here, and that is, yes, all of these things about rural healthcare facilities or real-time audio video, those do exist, and they exist in the world of capital T, capital S telehealth services. It's a traditional way that Medicare pays for that. It's under the Social Security Act, and a lot of folks will have pointed the finger at CMS saying, well, why isn't CMS doing anything about this? Why aren't we tapping into this? And to CMS's defense, to some degree, it's not completely their fault, right? These are criteria, those rural area, those type of criteria. They're found in the Social Security Act. It means, legally speaking, it would take an act of Congress legislatively to change that, and there really hasn't been an appetite for that fast change. It's really been a snail's pace, although there has been loosening up. So what CMS has done recently, however, is a little bit of legal gymnastics, I would say. And they've said, look, remote patient monitoring and some other virtual care codes as well, they're inherently non-face-to-face. So RPM will never be able to meet that slew of criteria because it won't ever be real-time audio video. So in fact, RPM is something different. And because it's something different, it's not telehealth. And we can promulgate rules about it and we can pay for it. And CMS has started and elected to do so under the Part B physician fee schedule. And they really started doing it quite frequently this year. January 1, 2018 was the first taste we had. It was CPT code 99091. That code had been around for about 16 years. It was kind of bundled along with some chronic care management codes. CMS just said, hey, we're gonna start paying for this code. Because it was so old, it wasn't really, I think, great for the modern way that RPM services are being delivered. It was a little clunky. Fortunately enough, just this year, January 1, 2019, these 3 codes on the screen here came into effect. And I think they do a much better job of really addressing how RPM can be or should be practiced today in the marketplace. The 3 codes, 99453, that's the code that will pay for the initial setup of the device and education of the patient. It's a one-time payment per episode of care. Then you have 99454. It's a recurring payment for the device itself, the device that's actually monitoring and capturing your information. The last code, 99457, that's to pay for the professional time of the actual monitoring of the information that's occurring here. So these are the 3 codes, and I'll go into them in a little bit more detail, but wanted to show them to you. So the quick hits for these 3 codes are, 1, here are the questions I get. Who can actually do the monitoring? Who can do that? Under the new code, 99457, you can have a physician do that. You can have a qualified health professional do that, which is like a nurse practitioner or a PA. But the kicker is you can also have clinical staff do it. So like an MA can do it. Much more level, cheaper sort of personnel can do this. This is under 99457. Who can bill for RPM? The people that can bill for this are going to be your qualified health professionals that can bill evaluation and management services under the Part B program. Typically, like your physicians are going to be the ones that can do that. What kind of device can you use? It has to be an FDA-defined medical device. Not FDA approved, not FDA cleared. That's a big distinction. It opens up the breadth. And this is all under the current guidance, which could change, but this is the current state of the land or the law. 16 days each month of monitoring. Doesn't have to be consecutive, but 16 days in the calendar month to have the device be used to monitor that, to get payment, and then 20 minutes of professional time. The old code 99091 had 30 minutes, so now they've reduced that to 20 minutes. That professional time does require at least 1 live interaction with the patient, either by like phone or video, but all of 20 minutes can be conducted by that clinical staff. Doesn't have to be the doctor, doesn't have to be the physician. So a lot of open questions still that we've gotten into the weeds with a number of our clients. Not a lot of answers necessarily. The code, the rule that was put out late last year, finalized for this year, had I would say it lacked a lot of precision. So there's a lot of questions. For example, when the rules first came out, they didn't provide or allow for any sort of incident to billing under 99457. CMS backtracked, said, hey, we're going to put out a technical correction. That's not what we meant. In March of earlier this year, they corrected that. We expect that to continue. We think it's going to be an evolving process. So for example, the proposed rule for next year, 2020, the physician fee schedule, that contained 2 significant changes that I think are actually helpful for the RPM opportunities that are out there. Probably the biggest one, I think, is the clarification that general supervision will be allowed for the 457 code. In other words, under the default rules that exist today, if you're going to build out a program and you want to use RPM, the doctor that's supervising is going to have to be in the same building as that clinical staff. But with general supervision, that doctor doesn't have to be in the same building. You can be immediately available by phone and satisfy that supervision criteria. And so that can really open up a lot of business models, a lot of different opportunities that wouldn't otherwise exist. That's very promising. Hopefully we'll see that come out in the final rule, should know sometime in November. The other significant change is it added a new add-on code, probably will be called 99498. That'll be for additional increments of 20 minutes. So if you go over that 20 minutes, you have a chatty patient, you have a lot of information that you're monitoring, it's a little bit more complex, you're going to get paid for it if you do 40 minutes. So that's also coming down the pike here. I know here we're focusing on RPM, so I won't go into these details, but if you're a company, a telehealth organization, or if you're in a hospital system, you don't necessarily are just limited to yourself to these 3 codes, right? There's other sort of, I would say, complementary service lines, complementary revenue streams, right? Transitional care management can be related, chronic care management, and then there's a new concept being released and potentially finalized January 1 of 2020 for principal care management. So these are also new-ish codes, new-ish revenue opportunities that you can have as a bolt-on service if you're going to play in the sandbox here. So we have a number of our clients that maybe were chronic care management, are transitioning RPM, or vice versa. So I'm out of time. The last thing I'll say for 10 seconds here is we're seeing similar trends in the commercial health plans, right? We're seeing a number of health plans that are, or states that are specifically requiring the health plans to cover RPM. So, this map shows you for telehealth, and these laws don't necessarily, or the map doesn't dictate the level or how much teeth are in each law, but a lot of states are specifically also starting to pass legislation. There's 14 to date that will address RPM. So we expect, or I expect to see a trend to cover this as well. So here's my contact info, and again, for the Q&A, feel free to ask us anything that you have that's a burning question. Thank you.